Welcome. So in this presentation, I want to talk about differential diagnosis of the wrist and hand for orthopedics and physical therapy. As I like to start every presentation, there are these reminders at the top for what is normally indicative of musculoskeletal pain versus more of a nerve pain versus a red flag or non-musculoskeletal pain. So I'll let you all read through that if you want. I want to get to the differentials, but that will be on the document link that I post. So in the wrist and hand, the main categories that I like to remind myself of or think of as being potential sources of injury in these areas are one, something due to usually a trauma or an impact injury. Commonly, our acronym for this at the upper extremity might be a FOOSH, so fall on outstretched hand is a common acronym that we'll use to abbreviate a mechanism that causes injuries related to trauma. And those injuries in the wrist and hand tend to present as fractures or instability. So ligamentous tear or laxity. Also, we think of impact if it's on the ulnar side of the wrist, could lead to tearing or disruption of the Tfcc, the ulnar side of the wrist joint. But what we're thinking about when we have these injuries is objective finding. Main objective finding we're thinking of is going to be tenderness at that area of injury, so the bone or the ligament, and then the mechanism is hugely important to make us suspect this sort of injury. Tendinopathy of the wrist and hand, or as tendons cross that wrist joint and enter the hand. So technically, I guess it could be both. This tends to be the mechanism and onset tend to be similar to other areas where we're seeing tendinopathy or tendon irritation. So chronic or repetitive overuse, repetitive stress injuries typically. It's not typically an acute, high force, one incident injury. It's this overuse, repetitive microtrauma where we have that irritation at the tendon. And again, I use the word tendinopathy because I think a lot of the research in this area tends to suggest that after a certain point, it's not so much an itis or an acute inflammation as it is maybe a chronic condition, or sometimes it's described as acute on chronic. So maybe have a little bit of an inflammatory component, but it's this reoccurring syndrome. We can also have tendon rupture, and this is commonly described in the finger flexor tendons or extensor tendons due to a mechanism such as like an acute laceration or a load, so like a crush injury or a laceration injury where the tendon is severed. And these injuries follow the same pattern that we would expect for a contractile lesion. So they're painful with active contraction and passive stretch on the muscle tendon unit, or in the case of rupture, that particular muscle tendon unit is going to be insufficient. So loss of active range of motion, loss of strength because there is no connection left. It has been severed. And then nerve injuries. If we're thinking about nerve injuries at the wrist and hand, there are these three main nerves of the upper extremity that come from the brachial plexus and then travel down the arm and into the wrist and hand and supply different muscles. So if we're thinking about more of the flexor functions at the wrist and hand, fingers, thumb, we're thinking of median and ulnar nerves. So they're going to share innervation of those different flexors, and I've kind of tried to break it down just in a simplistic sense here, but we'll go through it a little bit more below. And then radial nerve, we're thinking about posterior wrist and fingers. So those are going to be our wrist extensors, finger extensors, thumb extensors. And excuse me, I just had a drink. Okay, so in these nerve injuries, we might see some weakness. We might see some paresthesias or loss of sensation because these three nerves do have motor and sensory components. There could be reproduction of symptoms or pain with compression of those specific nerves. And you could have positive upper limb tension tests, although it's not a prerequisite for these nerve injuries. They could be affected more distally, in which case an upper limb tension test may or may not be positive. What we're really looking at is distal loss of function. So as these nerves cross the wrist, either they're being compromised or maybe in the hand there's an injury that's compromising these nerves, and so that's going to result in the loss of function that we see. Okay. So moving into the more specific diagnoses that we're concerned with in these areas, our fracture and instability category, I'd like to start with one of the most common fractures that we see in the upper extremity, which is the distal radius fracture, or commonly called a Colles fracture. So again, the mechanism is going to be trauma, usually fall on a hand. Pretty common in older individuals who may be more at risk for these fractures. You're going to have tenderness at that distal radius. You could apply a tuning fork test for fracture. That could be positive. And again, this is going to be kind of update as I go if I'm missing things, but X-ray findings for fracture is going to be kind of your gold standard for this particular injury. But localized tenderness and mechanism are going to kind of clue you in. The other fracture that we commonly see, and in fact the most common fractured carpal bone, so wrist bone, carpal just referring to wrist, is a scaphoid fracture. And so if you think about where the scaphoid lies, just right, kind of it's going to be in the proximal row of carpals, right next to the thumb or on the radial side of the wrist, in that anatomical snuff box area is where you can palpate it. This bone, as somebody falls on their outstretched hand, if they fall on that load-bearing radius or kind of like meat of the thenar eminence, they're likely to impact at the scaphoid side of the wrist and in that scaphoid area. And so trauma to that area can cause a scaphoid fracture. These individuals will likely present with tenderness at that particular bone. And again, you can palpate in the anatomical snuff box. And I'm just going to add, just like I did above, so X-ray findings for fracture are going to be the gold standard with scaphoid fracture, though I will make a note, it is a commonly missed fracture on imaging. And so sometimes what will end up being the better test for this, or the better diagnostic test, will be something like a more sensitive test like an MRI with better resolution, a CT scan, or in fact a bone scan. And these individuals, it's very important that this fracture gets identified, because there is the risk of avascular necrosis of the scaphoid, or malunion or non-union of this bone as it heals. And so again, it's very important that this gets diagnosed, and if need be, there is surgical fixation to address this fracture. So if somebody has a fall, a traumatic mechanism, but negative X-ray findings, and they're still presenting with significant tenderness in that area, and everything else kind of lines up with your clinical exam, it might be worth some repeat imaging, and it might be worth suspecting this particular injury and referring, even though they've had an X-ray or imaging. That's kind of a red flag, or something that's really important to keep in mind. Okay. So one of our instability diagnoses, and the most commonly dislocated bone in the carpals, is the lunate, because of where it falls, proximal carpal row, but kind of in the middle. It is, I guess, at risk for instability, and in particular, the lunotriquetral ligament, hyperlaxity, rupture, trauma would be probably the most likely cause of this instability, is somehow you have an injury to that ligament that holds the lunate a little bit more stable. So mechanism, like we said, it's going to be trauma. These individuals could describe a click or kind of a shifting sensation at the wrist, where they do feel a little bit of that movement of that carpal. Positive special tests for this particular injury, a lunotriquetral elopement, which is just stressing that lunotriquetral ligament, so assessing movement at the joint, the lunotriquetral joint, so between the lunate and the triquetrum. Positive X-ray, not necessarily, because again, this is a soft tissue structure. It's a ligamentous structure, so it might not show up on X-ray, but it might. And the reason it might show up on x-ray is because that bone may be displaced, either palmarly or dorsally, depending on how the instability is described, as either a lunate dislocation or a perilunate dislocation. And I know that's a little bit confusing, but it's basically the idea, did the lunate move out of place, or did all the bones around it move out of place? And so it's a little bit arbitrary, but basically what we're looking at is the lunate is not where it's supposed to be. So it's either displaced anterior or posteriorly. So that's where, if it's a significant disruption, it would show up on x-ray. But again, not necessarily if it's just minor. And so you could do follow-up MRI, which is kind of what I'm adding to that for a little clarification. Again, as I mentioned above, you do have this structure on the ulnar side of the wrist that almost functions like a spacer or a meniscus, if you will, at the wrist, and that is the triangular fibrocartilage complex, commonly abbreviated TFCC. So it's in the the ulnocarpal space between the ulna and the proximal rope on the ulnar side of the wrist. And with a compression injury or a kind of a compression grind or compression twist injury, just like you might think of for the meniscus at the knee, this structure can become injured. It can be torn or just irritated. And this could also cause a clicking sensation or a catch at the wrist, where wrist motions, flexion, extension, radial and ulnar deviation are not experienced as smooth. The other thing individuals will often report or experience, either subjectively or upon your objective exam, and this makes sense based on where this is as they move into ulnar deviation or ulnar deviation with added overpressure, they're likely going to experience pain, because that will be placing compression on this structure. It'll kind of pinch the proximal carpals into the ulnar bone, and as you can imagine, that's going to be painful if the TFCC is inflamed. So likely findings with this injury, you're going to have tenderness at that structure. So within that space, that joint space, you're going to be able to palpate the TFCC, and you'll have a positive TFCC grind test. So that's kind of, as I was describing, you're going to axially load that area. So you're going to compress and push those structures together, or the joint surfaces together, and kind of pinch that structure. If it's involved, it's going to be painful. Could have pain with overpressure into extension and flexion, just because that's going to decrease the joint space. And again, if the tissue's irritated, you're going to feel it. Okay. Another common ligamentous injury that we see in the hand is called gamekeeper's thumb or skier's thumb. So this is the mechanism for this is a forceful thumb hyperextension, and in particular, hyperextension of the first metacarpal phalangeal joint, or first MCP joint of the thumb. And it's an injury of the ulnar collateral ligament at that joint. So if you're kind of thinking about that, basically what's happened is that you have a valgus or a hyperextension overload stress at that joint, and injury at that ligament. And just like other ligament injuries, you could have a grade 1, 2, or 3. So different grades or degrees of severity, different grades or degrees of laxity, depending on how affected or how much trauma that ligament has experienced, how much trauma that ligament has experienced. But positive findings are going to be positive gamekeeper's test, which is, as you might expect, you're creating a valgus force at that joint to try to stress that ligament. The other thing is you'll likely have tenderness to palpation at the first MCP at the UCL. So that's kind of what you're expecting. And then the mechanism is pretty characteristic, so that's going to clue you in. All right, so moving on to these tendinopathies or tendon ruptures at the wrist and hand. Dequervains is a common one that we see that's described. Mechanism here, again, repetitive overuse. Sometimes it's called colloquially mother's thumb, and if you think about holding an infant and having to hold a position of maybe radial deviation at the wrist to hold that infant upright, that's going to preferentially load these tendons that we think are irritated or at fault in this syndrome. And those tendons specifically are the extensor pollicis brevis and abductor pollicis longus, which are going to be two of the tendons involved in that anatomical snuff box. You could have palpable nodule or point of tenderness. Finkelstein's test is the special test for this, where you grasp your thumb and ulnarly deviate to stretch these tendons. You could also have painful contraction of the abductor pollicis and extensor pollicis brevis. So that's our pattern there of painful active contraction, painful passive stretch. Could have painful radial deviation as well because of the contribution of these muscle tendon units to a radial deviation motion. Trigger finger, trigger thumb is a stenosine, so the technical term, stenosine tenosynovitis, usually or more commonly occurs at the second MCP joint, and it commonly occurs in these flexor tendons where this irritation forms, so the synovitis of the tendon sheath of the flexor tendon, such that the tendon gets stuck in the sheath, and oftentimes that finger gets stuck into a flex position, and the individual will have to manually pull it back out into extension. Could be the opposite way, but usually flexion is where they get stuck. And progressively, as this worsens, it may get stuck more and more and more. Sometimes people are able to actively bring themselves out of that position, but usually with a more severe or more progressed trigger finger, they have to actually passively or manually move themselves out of it. So the action of finger flexion or thumb flexion is going to be really painful. These are some risk factors for this particular issue, and if you think about it, those are common to other joint capsule irritation disorders that we see. So synovitis is just a joint capsule irritation, and in particular, what that reminds me of is kind of an adhesive capsulitis, frozen shoulder type set of risk factors. So if that helps you remember it, that's kind of what I have in my mind when I think about this sort of issue. Treatment for this could be, usually it's going to be conservative care, splinting and injections to start with, and then if necessary, surgical treatment. But really trying to reduce the source of the inflammation if possible, surgery to remove adhesions and try to free up that tendon if necessary. Flexor tendon rupture, as we said prior, you're gonna have usually a laceration. I'm just gonna put in here crush, injury, or laceration. So like a knife severing the tendon is kind of a common mechanism. Observation, also active insufficiency of muscle tendon unit. So those are pretty obvious, but I'll just throw those in here. So that's kind of what you're expecting. And then similar issue if you have an extensor tendon rupture, but just obviously on the opposite side of the hand, so dorsum of the hand. Treating with surgery, trying to, if possible, repair that tendon. Sometimes they will do a graft if need be. Another injury that we see to tendons in the hand is Dupuytren's contracture, which is a contracted or fibrotic flexor tendon where there's kind of a progressive like cording or thickening and progressive flexion contracture of the digits involved. These are usually observable or palpable, especially as they progress, they become more obvious. And this individual, again, is going to have a progressive kind of flexion contracture, so they're going to have reduced finger extension at that area. Treatment, again, early on, you're thinking about conservative care, splinting, but you may need to do surgery to free these areas up. Okay, so nerve injuries, and then we have kind of a catch-all treatment. I think we'll get through these. Let me see. I have one question here. Dupuytren's contracture, the question is Dupuytren's typically 4th and 5th digits? And I believe preferentially that is the case. I'm not as certain as I am about the trigger finger preferentially affecting the 2nd digit. So I might check on that. I'll just put a question mark in here and I'll go ahead and check that so that I can update the document. So it may preferentially affect the 4th and 5th digit, but I'm not positive on that. I have to look that up. Good question. Thank you. Okay, so for nerve injuries, what we're thinking about are those 3 main nerves to the upper extremity. Median nerve, the diagnosis here we're thinking about is carpal tunnel syndrome. So the median nerve is compressed as it passes into the wrist of the carpal tunnel. Positive handshaking sign is very common, in which the individual actually shakes out their hand to relieve symptoms. Could see swelling, but it's less likely. The gold standard for this would be nerve conduction testing, so an abnormal nerve conduction test, so NCV or EMG testing of that nerve would be kind of the gold standard to diagnose. However, you are going to see this cluster of signs and symptoms that is going to help you diagnose. So thenar dysfunction, because the median nerve supplies thenar muscles. You could have a positive Tinels, and then these actions that compress the nerve at the carpal tunnel are going to be positive for pain and paresthesia. So Phelan's test, prolonged wrist flexion, prolonged wrist extension are going to compress that carpal tunnel, or just manual carpal compression with your thumbs. That's another special test for this. Ulnar nerve, you're going to see loss of sensation where the ulnar nerve supplies. Could see, I'm going to say, dysfunction of the hypothenars, and then a positive Froment sign in which the adductor pollicis is dysfunctional. And there are others, but these are kind of the main ones. Radial nerve, you're going to see wrist drop, loss of sensation of the dorsum of the thumb, which is where the radial nerve supplies. Dorsum of the thumb, a little bit of dorsum of the hand, and then dysfunction of the thumb extensors and abductors. I'm just going to put extensors because abductor pollicis longus is thumb versus brevis is going to be median. So dysfunction of the thumb extensors and wrist extensors. Some other diagnoses at the wrist, and I apologize, I'm going pretty quick, but I want to get through just a couple more things here before we wrap up. Could see first CMC degenerative joint disease, or OA. So in the hand, that's going to be commonly the joint that's affected. Positive imaging findings are going to be your gold standard. So the decreased joint space and osteophytes and sclerosis, that trifecta of findings for degenerative joint disease. These patients are going to report stiffness and morning pain and stiffness, just like other osteoarthritic presentations. You're going to have a positive thumb ground test, so putting an axial load at that joint is going to be painful. There could be a loss of range of motion, and later in the disease, you could have joint deformities that are present. So those things could all be part of the clinical picture. CRPS, or complex regional pain syndrome. So there are different risk factors for this, but commonly you're going to see this following in prolonged immobilization or trauma, and it's a sympathetic dysfunction or sympathetic deregulation. And so because of that, you're going to see kind of this category of signs and symptoms. So sensory changes, vasomotor changes, pseudomotor, and tropic changes. But what that is going to look like is a limb that is abnormal. It looks abnormal. So it's either swollen, too hot, too cold, could be maladaptive or uncommon sweating. But this is really going to be the key in CRPS, is going to be the hyperalgesia and allodynia. So the hypersensitivity. So sensitivity and pain beyond the time with which you would have thought that tissue healing should have occurred in a healthy, normal individual based on tissues at play. So with a fracture, with a tendon, with a muscle injury, anything that we've talked about above, if those tissues should reasonably have healed and that person is still hypersensitive and they're showing some of these other sympathetic changes, after immobilization or trauma, you're going to suspect CRPS. That's going to be your diagnosis. Rheumatoid arthritis, I threw in here just because we're thinking about small joints at the wrist and hand. And rheumatoid arthritis is going to be a rheumatologic diagnosis, so not necessarily a musculoskeletal diagnosis. However, you may see it show up at the wrist and hand. And so this diagnosis is polyarticular. It's going to affect multiple joints, and it's going to have some sort of positive immune testing. So antibody testing is very common and should have some positive antibody testing for rheumatoid arthritis. And you're gonna have flare-ups and remissions, so like cyclic course of pain and dysfunction. And then some sort of inflammatory markers are gonna be likely present. So could be positive C-reactive protein, or erythrocyte sedimentation rate could be elevated. Could just be these cardinal signs of inflammation. So pain, swelling, heat, redness, your 4 cardinal signs. Likely one or more of those will be present. Pain or joint pain is going to be kind of your prerequisite. That's why the person's coming in to see you. Some Therax for wrist and hand. I'm just going to let you read through this. It's pretty general, but just kind of thinking about in the wrist and hand what phase of healing we're in and how we're going to treat most appropriately. So that is what I want to cover for wrist and hand. Again, I will post the link to this document at the bottom for your reference, and I will update it based on the changes that I made.